been over there?
Yeah, it's busy. We miss you guys. Obviously, you've given me a few extra hours to work on the robot, so I'm happy.
Man, there's two robots and you're still complaining. Oh my God. It's your partners that use too much of the robot. I'm just kidding.
Nah, I know.
No. That's fantastic, man. Well, we definitely miss you. I'm ready to come home. I'll tell you that. I'll be very honest. Hey Ben, can you tell us? I'll be very honest with you. I mean, it's time to go. I miss my kids and family, but we're almost there. We'll be in California on Saturday, so almost 2.5 days left.
Oh,
So
wow.
it's
You
awesome.
guys are going to be putting on some miles then.
Oh yeah, it's 6,000 total miles.
No, I meant in these next 2 days, you're going to be putting on quite a few miles to get to
A
Wisconsin.
lot, a lot. It's gonna be a lot of driving, but we have an RV, and then we have this, and we have about 12 drivers,
Yeah,
so it'll be good.
good.
So Chris, Dr. Johnson is a dear friend of ours. He's a pioneer in robotic surgery when it comes to its implementation in general surgery, and we're very fortunate to have him on with us on this drive for men's health. Now, Chris, I know you see a lot of male patients in your practice. I think we've seen some of them. Just to kind of start off generally, what do you think it is about guys that they're always last to take care of themselves?
Wow, we're busy. I look at yourself, look at myself. I do the same thing. It's just it's a time management issue. We've always got something else to take care of.
Well, even when we're not busy, I mean, I'm just bumming around, and going to see a doctor is so easy. I could just call you and come to your office, and I still don't do that. So, other than just being busy, do you think it's lack of awareness? Do you think it's lack of education on preventive screening? Like, you deal with people that get colon cancer. You deal with people that come in with incarcerated hernias. That stuff doesn't happen overnight, right?
Right. No, it's I think there's less of an emphasis on screening for men. Probably until after the age of 50, then we start talking about prostate, we start talking about colon, we start talking about other issues. So I would say probably we just don't think about it before, and we probably need to redirect that focus, catch folks when they're a little younger.
Yeah.
But it's tough, it costs money, it costs time. For the most part, I think men hold, the job. They don't really have time to take off from work, or if they do, they're spending with their families.
Yeah.
Going to the doctor isn't a priority.
Yeah, and we actually before we went on this drive, we did a survey where we surveyed 1,000 men, where we basically asked them, number one, what was the make and model of your first car, and number two, when was your last doctor's appointment? And what we found was that over 80% of men remember the make and model of their first car, and only about half remember their last doctor's appointment. So you're absolutely right in that most people don't remember and don't care. So we're gonna try to change that. So we're gonna try to change that by giving some education, and starting off with education on some of your specialties. And I know one of them is robotic surgery, which you perform for a lot of reasons. One of them is for management of certain kinds of colon removals. Is that correct, or am I wrong in that?
Yeah, so I guess if we're looking at trying to capture the younger population, there's a couple things with colon that we should be aware of. Appendicitis is certainly one of the most common conditions that occurs today.
Yeah.
But colon cancer, certainly in the older population, we typically see a higher incidence in the late 50s and 60s than we do in the younger folks. So I guess it depends on where you want to go with the talk, but we can hit the age groups and different categories.
Chris?
You still there?
Yeah, go ahead, man.
Yeah, okay. So, colon cancer, yes, we do a lot of robotic surgery for colon cancer. We do a lot of open surgery for colon cancer. The best screening tool, it's totally preventable. So the best screening tool is colonoscopy. Folks that get in and get their colonoscopy at age 50 or earlier with risk factors certainly can avoid the need for an operation. We do nationally probably 170, 180,000 colon operations. for colon cancer, and it's totally preventable.
It does.
Okay.
It does. But it's cool because that way they.
Sorry, we're driving, so you kind of get cut off a little bit. So I apologize for that because we're driving and we're in the middle of nowhere.
No, this is Rockford, Illinois. It's a great city.
You've been here before?
No, but it looks like a great city.
Sorry, Chris. Go ahead, man.
No problem. So, yeah, colon cancer is definitely preventable. We do a lot of robotics with that. Fortunately, we catch the disease early enough. We can prevent them from having oftentimes a need for chemotherapy, radiation therapy, or we can kind of one and done. We get the surgery done and they're finished. I'm sure it's like early prostate cancer. We catch it early enough that we can definitely treat it and not have to worry down the road.
We had one question about like blood in the stool, and one of our younger patients on the road was like, "Well, it's just hemorrhoids, and it can't be colon cancer." So even if it's like if you're like 25 and you have blood in the stool, do you need like a colonoscopy?
Well, you definitely need a history of physical. You need to know what the risk factors are. You need to know if they have a family history of colon cancer. Do they have a personal history of colon disease, inflammatory bowel disease? You need to know if they have change in their stool. Is the blood what's the nature of the blood? Is the blood just something they see on the toilet paper, or do they see it mixed in the stool? Do they see a change in the stools? Are they having black stools? So there's a lot of things that go with the history and physical. Just a brief rectal exam can really help you identify if they have any anal pathology. But I would say in the age group of 50 or older, or in an individual that has risk factors for colon cancer, such as a family history, I think you definitely need to proceed to colonoscopy in those individuals, regardless of age. And we would typically start if they have a family member who was diagnosed with colon cancer at the age of 55, then they should begin their own personal screening 10 years prior to that diagnosis. So they ought to get their first colonoscopy at 45. And if they're having symptoms before then we may start their screening even earlier.
So how has a robot changed some of these interventions for you?
Well, from the screening aspect, really not. I mean, that's not really the purpose of robotics, is a screening measure. The robotics is a minimally invasive approach for us to treat the patients that already have diagnosed disease. So for us, the biggest advantage of using the robot or a laparoscopic approach is just the length of stay, the faster recovery. They tend to get out of the hospital a little faster when you compare these to the patients that have, say, open operations or who have complicated colon cancer that have obstruction or perforation or other issues where they may need multiple surgeries. They may end up with a diversion such as a colostomy.
Wow.
So robotics is a way to treat disease when it's early, to treat disease in a very sort of efficient manner and get them in and out of the hospital. In my own hands, I see a shorter length of stay. Patients are home in usually under 3 days. And compared to my open operations, those patients are in the hospital 5 or 6 days. So the recovery time is the biggest advantage for the robot.
What's funny is you mentioned stoma. So I don't know if you've been watching, but yesterday we
were
have
stomas. Yeah.
we got,
yeah, we were wearing
stoma clothes.
Yeah,
stoma clothes,
you know about that? You know about that?
Yeah, sure. Well, yeah,
we
absolutely.
wore it for a day just to, and it's very humbling because you realize, like, just sitting in the car, the seat belts, the posture you're at, it really is a life adjustment. And it was actually a pretty humbling experience. I've never worn a stoma before, and it was an experience.
Yeah. Well, the good news with most colon surgeries is that the stomas are not permanent. We can usually get them reversed later, but a few patients do have permanent stomas, and I think it's key that you take into consideration where the stoma is placed, what their activities are, what they need to do, how they wear their pants, where they wear their belt, how they sit in the car, where their seatbelt is. I think all those things are extremely important when you're talking to the patient about a permanent colostomy.
Yeah. So that was great. And then in terms of, I know you had mentioned a little bit about hemorrhoids and stuff, and you have a new device, right, that you're using for hemorrhoid treatments and stuff. That's less invasive, right?
Yeah, well, the standard of care is still likely, just excisional hemorrhoidectomy. That really hasn't changed a lot. But there are some less invasive techniques, ablation, cauterization, that can be definitely easier on the recovery end if they have, grade 1, grade 2 hemorrhoids that are early and treatable. Even banding can be done in early hemorrhoid disease, which is generally not painful at all. If they get very bad hemorrhoids, grade 3, grade 4, they have prolapse, the tissue doesn't reduce, spontaneously. Maybe some folks even have to manually reduce their hemorrhoids. That's a little more complex. That's going to require a formal surgery.
So I know we had talked about you had some type of tacking device, right? So that's only for very small hemorrhoids then, or early stages?
Sigil's just trying to get out of the surgery with you, okay? He just wants something tacked in the office.
Yeah, it's actually still done in the operating room. We still have to have relaxation. The least invasive approach for minor hemorrhoids is banding. That's definitely the way to go.
What about preparation H? Isn't that the least invasive?
Well, sure. So for grade 1 disease or intermittent disease, if we can fix their cause of their hemorrhoids, most of the patients just have straining and constipation, and so if we can fix that, there are many hemorrhoids that don't require treatment at all.
Oh wow, that's cool.
So maybe we just need to work on Cito's diet.
That's right. Maybe it's my diet.
Dude, I think. Oh my God, you don't even want to know.
I've definitely got some irritable bowel or something. So.
Hey, Wayland. Hey, man, we're here with Dr. Johnson talking hemorrhoids, bro. You have that problem too?
Hemorrhoids, oh. Well, aren't those just varicoceles to the other organ?
I don't know.
Yeah, aren't they just your version of varicocele? That's a good point, Wayland. I like that.
You can use a robot to fix them, actually.
Yeah, maybe.
Oh man, so that was great, man. So, but hemorrhoids, are they? We have a lot of guys asking about this, and I know colon cancer is all sexy and stuff, but hemorrhoids, I think, is probably more common, and they're definitely there. I know they irritate people, and I actually have to deal with them as well, because when I'm about to give a rectal exam, sometimes hemorrhoids get in the way, and patients will not let me check their prostate because their hemorrhoids are so bad. But there's two kinds of hemorrhoids, right? Right, Dr. Johnson? There's like internal and external. Can you mind kind of differentiating between them two and what the difference in treatment options is?
Right. So hemorrhoids occur in the anal canal, and we have a margin called a dentate line, which differentiates the rectal tissue, which is made up of a soft lining, a mucosa like your cheek, and then the anal canal externally is made up of skin. And the dentate line is sort of the separation for those structures, and internal and external hemorrhoids occur above and below that line respectively. Typically, there is a lot more nerve endings on the external side, so patients that have external hemorrhoids typically have a lot more symptoms, such as pain, and patients that have internal hemorrhoids typically have more issues associated with itching and or intermittent bleeding.
So is the treatment, is the treatment the same, even if they're internal external? So I know you mentioned.
No. Yeah, so the treatment would be a little bit different. Internally, there are very few nerve endings, nerve fibers on the rectal tissue. There are more pressure or stretch fibers. That's how it determines when we need to use the restroom. It's a pressure or stretch phenomenon, not a pain issue. And so those you can treat by banding. Basically, you're causing necrosis of the tissue. You're pinching off the.
Man, that was hurt, man.
No, it doesn't hurt at all. That's the thing, because there are no nerve endings above that dentate line in most patients. So banding is very effective, and it's the same thing with excisional hemorrhoidectomy. It's very effective internally, and very little recovery with that. External component is much more painful. So patients that have external hemorrhoids, they often end up with clot or thrombosis of those hemorrhoids. That can be very painful process. It's usually very acute. It's acute, and it's usually intermittent.
Wow, that's some good stuff. Well, that's pretty cool, man. So top 3 things from a general surgery standpoint men need to take better care of themselves about. Number 1, Dr. Johnson.
Number one, just we need to be healthier. We need to be focused more on our diet. We need to get good sleep. We need to take care of ourselves.
Oh my God! Don't even talk about sleep right now.
I know we're definitely appreciating the sleep components.
Or lack thereof.
I think
Sleep is healthy.
next year we're adjusting the tour a little bit. So,
Number two. Number two.
Number two, get to the doctor. An ounce of prevention is worth a pound of flesh. You know what I mean?
Yeah.
So get to the doctor and get routine screening. And men early.
Number three.
Number three. As you get older, you definitely got to really focus on number one and number two.
Wow, I love this guy.
Nice. So again, for any of the listeners out there, this is Dr. Johnson. He's based out of Claremont, Florida, and he's absolutely outstanding. So everything will be recorded and archived. So if any of you want to listen to this again, you can just access the archives.
Awesome, man. Well, Dr. Johnson, thank you. You're more than welcome to stick around. We have a very exciting team of us. Dr. Wayland, I can't even say it. What is your... I don't even want to say it out loud.
It's Shao. Shao, like shower, without the
I know
ER.
Shao, but your topic.
Oh, my topic. All right. So, the talk I have today is about what to do for cancer survivors that have a 0 sperm count.
Oh, I thought your talk was about marijuana.
I'm still working on that one.
Oh!
I got distracted.
Look at this. Okay.
You driving through Colorado?
We have like millions of people watching.
This is like total blue balls, dude.
Waiting for the marijuana talk.
Waiting for the marijuana talk.
Especially these guys.
I was still working on that one. I'll get it to you later.
Is that talk even legal before you get to Colorado?
All right, man. Go ahead, bro. Go ahead, John.
Okay. Dr. Johnson, thank you.
Yeah, guys, no problem. I'll catch you later.
Okay, all right. Take care, Dr. Johnson.
All right. Well. So first of all, how far are you guys? Where are you?
Where are we? So we're headed to Minnesota from Chicago.
Yeah. That's great. Well, now, so I don't know what's the best format for this. How do I put up slides? Do you guys want slides? Do you just want to talk?
No, if you want to put up slides, you can. You can go on the left here, click on the second, the green screen share.
Yeah.
Share your screen, or we can just have a conversation. But if you've done slides, then just click on the green, and then share your screen.
Sure.
Green, share your screen. Now, how about to run out of power? Do you think?
What time is it over there? Let's see. So, all right, can you see it?
Oh yeah, there you go. There you go.
There you go. All right. Now, how do I? Here we go. All right.
Is this a can talk, or you really worked on this?
No. I mean, I'm
kidding. Wayland.
I mixed and matched. Okay, I'm still working on that marijuana one, man.
That's what everyone cares about.
Bottom line is, it's probably not good for sperm, but whatever. But let's talk about stuff where there's some better science. So just wanted to give a couple-minute talk here for men to talk about, especially for our cancer survivors, right? They've battled cancer, they've come through. And now, they found that they've had a 0 sperm count. And like most cancer survivors we're seeing now, their cancer was treated 20 years ago, and they didn't really talk about fertility preservation then, okay? So let me give you, for disclosures, I don't get paid by any companies. I just work in medical practice.
You get paid by me for being fun.
But, and not to get too academic, but this is a short talk. But, advances in cancer treatment really have led to better survival for these men. And, there's an increasing recognition in all of medicine that cancer survivorship is important. And paternity certainly is one of these significant quality of life issues. And so this term oncofertility bounces around all the time, guys. So, and what that term means, it just involves preserving your fertility near the time of cancer treatment, as well as treatment after chemotherapy if there's a 0 sperm count. So, what are the goals of it? The goals of modern oncofertility are basically trying to freeze some sperm, whether it's ejaculated sperm or sperm we get through procedures. And as of present, without sperm, we're not able to preserve fertility. Okay, so there are some people out there that talk about freezing tissue. Those are all experimental protocols as of right now. However, in the rush to treat cancer, and this is totally understandable, they overlook fertility preservation. Historically, that's what's happened, and even nowadays, they overlook it a large amount of the time. So, they're always, what are the excuses? What are the barriers to really banking sperm prior to chemotherapy? Well, first there's a lack of time for discussion. Well, there's a perceived high cost. There's a lack of convenient facilities and a lack of training about options and treatments. Well, let me answer these. So listen, if you don't have time to talk about it, we'll send the patient to a reproductive specialist. And on the male side, that would be a reproductive urologist like we all are here. Cost is always something that's an issue, but cost is man-made. We can fix this, okay? Lack of convenient facilities. Nowadays, a lot of these sperm banking companies will even let you ship samples. So, the fact that there's not a sperm bank right there really isn't a good excuse, all right? And finally, they always talk about how there's lack of training about options and treatments. Well, again, either the doctors need to learn about it or send it to a specialist. So this is kind of a busy slide, and it's getting late for you guys. I know you guys have had a long day. But, the challenges to banking sperm in pre-chemo setting, in the pre-chemotherapy setting is, as a reproductive urologist, what we always have to do is we have to balance the time.
Wayland, are you moving your slides, or are you still on the first slide?
I'm moving them.
I don't see anything. I just see the first slide. I want to hear you, man. You go back to your face.
Oh. All right. Well, whichever. Yeah. Let me. How do I do that? Red for not share.
Just cancel your screen share.
Cancel. All right. Stop share. Got it.
No, I still see.
There we go. All right. Well, sorry, man. I guess I'm not as high tech as the Pure Clinic.
Oh my goodness. Oh my god. No. I can see it. It's just, but I would rather see you talk.
There's some delay or something.
Yeah.
It's just, yeah.
Well, we'll go through this. So, in terms of pre-chemotherapy, you just got to balance. As a reproductive urologist, we need to make sure to work quickly so we don't slow down chemo. And, after chemotherapy, there's a lot of uncertainty too. And probably most importantly is, how much sperm is going to return, what their sperm counts are going to be like. And also, what's the quality of sperm, but that's an open question. All right. So really, I just wanted to talk a little bit about, what men can do if their sperm count is 0 after chemotherapy or radiation. And, first of all, they should be seeing someone like us, so a reproductive urologist. The first thing for any of you cancer survivors who are watching is that, our job as reproductive urologists, we're going to want to get a basic evaluation. So we're going to start off with 2 sperm analyses. We're going to look at genetics. We're going to look at your hormones and your testosterone levels. For men that have testicular cancer or have had surgeries in the back, they could have problems with ejaculation. So we're going to ask about that. We're going to do a good exam. Okay? And just like in the pre-chemotherapy setting, the whole idea, if sperm count is 0, is let's figure out what it is. So it's either some blockage or it's poor production, okay? And for men with poor production, and that happens after chemotherapy, the best option probably is what's called a microdissection TESE, or a surgery where we get sperm out of the testicles, and we get them, and you can either use them fresh with in vitro fertilization, or you can freeze them and use them later with in vitro fertilization. And, it used to be for these guys, they thought, well, there's just no chance, I'm sorry. But, the biggest study that was published on this was published out of data where I did my fellowship out of Cornell. So in the Cornell series,
name dropping.
So in the Cornell series, they were able to find sperm in 37% of men. Now that's not 100, and my whole practice philosophy is realistic expectations. That's a little bit less than half, but in 37% of men, they were able to find sperm. With that sperm, they were able to get a 50% clinical pregnancy rate. So, you know, even if it's 0, there is a chance you can find sperm, though it's not a slam dunk. Okay, and you know, the other thing is for men with testicular cancer, there are really unique problems there because at least in testicular cancer, we're removing one of the sperm-producing units. So we're down one unit, and also some of the therapies for testicular cancer, we end up doing surgery on the back. So when you do surgery on the back, what happens is the ejaculatory reflex can be disrupted. So in that setting, you know, there's good data that you can either do a testicular sperm extraction, get sperm out for IVF that way, or you can do a procedure called electroejaculation, which is a procedure for men that have sensation. It's usually done under general anesthesia, but we're able to get tons of sperm out, and they can use it with IVF. Or intrauterine insemination too. But I mean, the overall message is number one is if you've been diagnosed with cancer and you're about to undergo chemotherapy, I mean, have them slow down for like a half day there and talk about freezing sperm, okay? Because that's going to make your life a lot easier down the road. Because I know it's scary enough to hear that diagnosis right now, and you're thinking, you know, my God, am I going to be here? But especially with a lot of these cancers, the survival rates are really good, especially for testicular cancer and some of the other pediatric cancers, that you may be crossing that bridge. And it's a small investment for something down the road. And even the patients we're seeing now, where about 20 years ago, they didn't really talk about fertility preservation. There's stuff we can do. So the message is come see a good reproductive urologist. And there are techniques out there. None of the stuff we do is 100%, you know, just like anything in medicine, but at least there's a fighting chance, you know, so that's kind of it. That's the message.
You know, a lot of people, you know, yes, you have this problem now, let's deal with it, but what if someone is going through, is this expensive to freeze sperm?
Yeah, you know, freezing sperm, now prices seem to vary all over the board. Now I've heard anywhere ranging from $300 to $3,000 in my neck of the woods. And the average I see is like $300 to $600. And a lot of people do balk at that. It's the companies I use, usually it's $300 to $600 for processing and the first year of storage, and storage every year is around like $200. But if you think about it, $200, so that's like a little bit more than 50 cents a day, you know. And
because your kid's gonna cost you a lot more than that.
I know. I mean, you guys aren't using any gas on this trip, but the gas would cost you more.
Well, it's fantastic. I mean, it is very frustrating. Now, what about you can't find any sperm? I mean, then you can adopt, right? And then now there's like, you can find sperm that look just like you, right?
Yeah, that's a great question, man. And, you know, I'm so glad you brought that up, Jamin. And you know, whenever I talk about fertility and doing all this, I promise myself when I start doing fertility, I always bring up adoption, okay? Because there's lots of kids that would love to have 2 awesome parents, okay? And then you can also use donor sperm if your wife really cares about being pregnant, and but you know there's nothing there. And the beauty with donor sperm is, especially if the counts look okay and if there are no female issues, usually they can use intrauterine insemination to use it instead of.
Really?
And that's a lot cheaper.
Oh wait, I didn't know that. So they don't have to do IVF. They can just if there's enough to do IUI.
I mean, there's a lot of factors involved, and really, you know, men, you need to have your wives talk to their reproductive endocrinologist. But no, they can usually use IUI if the counts are adequate and female.
Wow,
you know,
that's interesting. Yeah, because one of the world's biggest cryobanks opened up in Orlando. They say we have the best looking people.
Oh no, man.
Well, that's pretty cool, man. I mean, this is fantastic, and this is stuff people don't talk about. Is prevention. We want to prevent you having infertility in the future. And I've had a few guys that got testicular cancer and stuff, but half of them take us up on the offer, and half of them don't. I don't know what to do with the other half. I mean, I have the girlfriend there, partner there, and they still don't care. I mean, there's only so much we can do.
Yeah, I mean, I'm right there with you too. I mean, you know, in my practice too, not everyone takes me up on it, but I think as a field, it's our responsibility to offer it. But it's a free country; they can do what they want, and certainly the data with sperm banking is not everyone ends up using it, because a lot of guys, the sperm will return after chemo. It depends on what kind of chemotherapy they get. You know, sometimes a cancer prognosis isn't always so great that they're here 20 years later. That's another reason. And, you know, so there's lots of reasons that it's not always used. So, you know, these people that talk about banking for everybody, like in the our recent national meeting at our American Urological Association, they talk about it for prostate cancer, right? Well, that's probably a bunch of 60-year-old guys that may not need it frozen.
We talked to someone recently this week about that, and you know, there's a lot of guys on Wall Street and guys that are having children later on in their life that do bank it. I don't know if I'm a big fan of it. I don't know if I advocate for it, but you know, I think it's cool. Men are thinking about their fertility. I think it's pretty cool. Speaking of fruit, we all want to hear this marijuana talk. So when are we doing that?
I may have gotten too distracted, but I'll look at it.
Yeah, we want to hear it, man. We want to see.
Out in California, everyone asks about it. I don't know in Florida.
Everyone asks about it here too, man.
Man.
Well, Wayland, thank you so much for joining us. I mean, this is fantastic. It's definitely something that people don't talk about.
Thanks, Wayland.
Oh, you're welcome, guys. Drive safely, man. Don't look at the screen. Look at the road.
Yeah, the sun is setting here, and we're headed to our next stop. But let's definitely find a time, even if it's after this drive. I would love to engage you in this conversation because I myself want to learn about this topic. So thank you.
All right, I didn't hear anything, man. All right.
All right, bro. We'll talk to you later.
Man. Take care. Drive safely.
All right, bro. Thank you.
All right, man. You guys are doing it.